Hi everyone, I'm Fadil and this is my unique case presentation. My unique case was obtained at an outpatient clinic during my fall 1 clinical rotation and is based upon a female patient of middle age coming to the outpatient clinic for a physical evaluation or checkup of their lungs because she had a history of tuberculosis, so this was actually like a follow-up to make sure her lungs were in a stable condition. Basically what we did was perform chest x-rays. The patient said that she was diagnosed with tuberculosis in 2001. Upon investigation, we saw that she had a prior chest x-ray at the same clinical site on the 7th of October of 2015. However, this current chest x-ray was done on the 11th of October of 2017. She had a pacemaker inserted in her chest wall of April of the same year 2017, and she complained of having a mild cough with wheezing and phlegm for the past couple of weeks. At the time of the examination, she had no complaints of any chest pains. She had no complaints of any difficulty breathing, shortness of breath, dyspnea, basically. She had a hyperstenic body habitus, and also we observed that she had limited mobility and was a bit slow in moving into the desired positions we needed. So we had to alter our patient care in order to acquire the desired images we needed. So the procedures we performed were the routine images of the chest, which are the PA chest x-ray and the lateral chest x-ray. As you know, both are done at 72 inches SID, as you can see in the diagram showing us the posterior and anterior chest x-ray, how it is done. The patient care we provided now. Since this patient had a pacemaker installed earlier in the year, and it was observed she had limited mobility now, additional assistance time and patience were required to achieve the PA and lateral positions we desired now. We had to be careful how we moved her so as to acquire the correct positions we needed. What we did was that we gave her arm support, so keeping the arms high raised enough for the lateral position so that apex of the lungs could be visualized well. As you know, in tuberculosis, the apical region of the lungs is where you would find the pathogen basically now. However, one good thing was that she was able to follow the breathing instructions we gave her and no repeats were needed, so we only took 2 images in the end. Now, this slide basically shows us the chest radiograph that was taken on the 7th of October of 2015 now. This was the one she did approximately about 2 years ago. As you can see, there is some sort of opacity occurring in the right upper lobe of the right lung. So, if we were to go to the radiologist's main findings now, he said that there were airspace opacities with bronchitic changes identified within the upper lobe of the right lung. As you can see here, this is the upper lobe of the right lung, and there is actually an opacity, which is the white area in the upper lobe here. Opacities are basically the filling of the bronchi or the gaseous areas of the lungs, which could be the bronchioles or the alveoli sacs, with materials which could either be solid in the form of cells or liquid in the form of fluid that attenuates X-rays more than the surrounding lung tissue. So basically what happens with opacities is that they accumulate with what could be fluid and they attenuate or absorb the X-ray beam now, so they appear white on a chest X-ray, whereas the areas with increased penetration will appear black. As you can see, this area is more white and this area is more black now. These opacities causes pulmonary consolidation, which is seen as a difference in relative attenuation of the lung. So if we were to look at the area just below the opacity, it would appear more dark because there are more penetration and transmission of the X-ray beam in this area, compared to the opacity where there were more attenuation or absorption of X-ray beam, so this area would look more white. So one thing we can note about opacities is that it decreases transmission and increases absorption of X-rays. So we require increase in technique whenever we image opacities of patients with tuberculosis. It's an additive pathology basically. Also, with opacities, the radiologist mentioned bronchitic changes occurring now. Bronchitic changes refers to the inflammation of the bronchial tubes occurring within these opacities. So basically the bronchial tubes within the opacities now, they were actually being inflamed. That was the radiologist finding now. So remember that opacities require an increase in technique because they absorb X-rays due to them being filled with either fluid or solid material, and also this opacity was undergoing bronchitic changes in 2015, which is basically the inflammation of the bronchial tubes. Okay. The radiologist also noted that on the same 2015 chest X-ray that the opacities and the bronchitic changes can be as a result or consequence of prior tuberculosis. Basically what the radiologist meant was that due to the prior tuberculosis, these opacities may have been formed due to that. It's actually the sequelae of TB resulted in these changes. That's what he basically meant now. Remember that TB results in the scarring of lung tissue and the growth of nodules now. Due to this, the radiologist said that the opacities formed basically now. Also, he noted that there was a small nodularity or nodule located at the right lung base. This is the area of the right lung base. As you can see here, this white area represents the nodularity or the nodule that the radiologist was speaking about now. A nodule is basically a small clump or mass of tissue that can form due to an inflammation or infection like TB. Remember, this patient was infected with tuberculosis, so this nodularity could have formed due to the tuberculosis the patient had now. A good point is that if this nodule was larger than 3 cm, it would have been considered a lung mass and could possibly be cancerous, so this could have been a potential hazard for the patient basically. Other findings the radiologist noted was that the left upper lung field appeared clear. As you can see, the upper lung field of the left lung is relatively clear. There are no opacities in the left lung. Out of the two lungs, I would say that the left lung appears much clearer than the right. The radiologist also said that the cardiac silhouette, which is the outline of the heart, is within the normal limits and it's seen as normal. However, he suggested that there could be dilation of the aorta. The aorta is in this region here, and he suggested that there could be dilation of the aorta. He also said that the trachea is shifted a bit to the right. As you can see here, it is not in the midline, but it's a bit towards the right side. And no pleural effusions, he said, are seen. Pleural effusion is basically the buildup of fluid in the pleural cavity, and he did not observe any of those changes in the 2015 chest radiograph. So basically, the things he saw in the 2015 chest radiograph was that opacity at the upper part of the right lung with the bronchitic changes. He saw the nodule. He saw the trachea move towards the right side. He said that the cardiac silhouette was within the normal limits now, and he suggested dilation of the aorta with no pleural effusions though. So if we were to go on now to the chest X-ray that was took on the 11th of October of 2017, this is the one that we took a few days ago now. This is how the patient's lungs looked right now. As you can see, this metallic device is the pacemaker that is observed here. So this is the current chest X-ray or the current visualization of the patient's lung as of now. And the findings in this chest X-ray was that there is stable opacity visualized in the upper lobe of the right lung, as was observed in the comparison done on the 7th of October of 2015 now. As you can see, the opacity is still there in the upper lobe of the right lung in the 2017 chest X-ray, but the radiologist on this occasion said that it is stable, meaning that it's relatively okay. It's not as bad as how it was in the 2015 chest X-ray. It appears to be going into a state of remission, possibly. However, the radiologist did mention that there's adjacent bronchiectasis present. Bronchiectasis is basically the widening of bronchi, and it appears as tram lines running parallel to each other on radiographs. Basically, it's basically the expansion of the bronchi and the bronchioles, basically. Other findings the radiologist found was that the left lung appeared clear again, as was seen in the 2015 chest X-ray. The cardiac silhouette was not enlarged again, but however, as we had seen before, the trachea is shifted towards the right side now. And not forgetting that a metallic device, the pacemaker, is now seen in the 2017 chest X-ray. The impression the radiologist got after comparing the 2015 and 2017 X-ray was that there was a stable appearance of the right lung in comparison with the 2015 chest X-ray. So now he said that the right lung appeared much more stable than the prior chest X-ray that was taken. So now what I did next now was that I put together the chest X-ray done in 2015 and 2017 with the chest X-ray. This is not the patient's chest X-ray. This is a sample chest X-ray showing active tuberculosis. I did this basically to show the progressive changes of the pathological condition seen in the patient. When the patient was infected with tuberculosis in 2001, this is a sample of what the upper lobe of the patient's right lung would have looked like. Remember that tuberculosis results in the scarring of the lung tissue and the growth of nodules, and is seen in the apical regions, as you can see here. Due to this scarring and the growth of nodules, it resulted in this opacity being formed in the right upper lung when what was seen in the 2015 chest X-ray now. And this opacity again is seen in the 2017 chest X-ray. But however, in the 2017 chest X-ray now, it seemed to have gone into a less prominent state or a remissive state, in which is not as intense or active as it was in the 2015 chest X-ray now. Also, the nodule that was seen in the 2015 chest X-ray is not present in the 2017 chest X-ray now. So basically, this 2001 would have been an idea how the patient's lungs would have looked. This is how it looked with the opacity in 2015, and this is how it looked with the opacity in 2017 that went into a state of basically remission. Next, what I did was that I made notes on what I saw in both of the lungs according to the radiologist's findings now. Firstly, I must say that opacities need an increase in exposure factors to be well visualized in radiographs. It's basically additive pathology now. Remember that it attenuates or absorbs X-rays more than the surrounding normal lung tissue, so you need to increase the exposure technique in order to have adequate penetration to visualize this pathology. With that said, I thought that the opacity in the right upper lobe appeared to become less prominent over the years now. It seemed to have gone into a state of remission. It basically subsided in my view and became less intense or active. Basically, I thought that it became less prominent in the 2015 chest X-ray compared to the 2017 chest X-ray, compared to the 2015 chest X-ray. Also, with that said, I thought that the right lung appeared more clear in the 2017 comparing it to the 2015. Now, as you can see here, it appears to be much clearer and more penetration than in the 2015 chest X-ray. These changes could have been as a result of the treatment and antibiotics the patient was on. Also, the small nodularity noted at the right lung base in 2015 now, as you can see in this area here now, is not visible in 2017 chest X-ray now. Also, the cardiac silhouette in both chest X-rays now were within the normal limits, and also, as you can remember, the trachea on both images were shifted over to the right. No pleural effusions were present in any of the images, whether it be 2015 or 2017. However, the suggested dilation of the aorta in 2015, that finding was not observed in 2017. The radiologist didn't make any note of the aorta being dilated in 2017. However, the overall impression now was that there was a much more stable appearance of the right lung in comparison with the 2015 chest X-ray now. I hope I was able to teach you guys something today, and I'm happy that you guys looked at my video, and thanks for watching. This is just my citations now, and thanks for watching my video again.